Alright, for our final talk, we are going to walk through some of the imaging modalities that are used when looking into abdominal pelvic complaints and looking at how the GI and pelvic symptoms might be dealt with. So the first step is generally going to depend on what the complaints are. So if someone has right upper quadrant pain, we're thinking possible gallstones. So ultrasound would be used right there. Abdominal pain plus inflammation, you might want to get a CT scan for that, as you would for obstruction, lack of bowel movements. Abdominal pain and weight loss, that's going to be indicative possibly of a malignancy of cancer, and that's going to be CT. Abdominal pain and diarrhea, actually a little bit unclear there because you're going to have a little bit of info regardless of the imaging modality first. You're probably going to try some other treatments ahead of time. And then difficulty swallowing, we have something very interesting. We have the video fluoroscopy that can be put to use to allow us to actually take a look at how the swallowing takes place and if anything is being left behind in the throat or if swallowing is dysfunctional because of the muscles. So let's start with right upper quadrant pain. Essentially, right upper quadrant pain should make you think gallbladder until proven otherwise. Other stuff can cause it, but gallbladder is going to be right at the top of your list. So an ultrasound gives you a very quick view of what's there. We can see here the gallbladder, nice dark area here, and we have a little bit of shadowing behind this thick gallstone. So objects that are solid are going to block the transmission of sound waves past them, and that's going to be leaving this shadow here, and that's resulting from the gallstone right there. So, as we've mentioned in the talk on innervation, GI pain that originates as visceral pain is generally going to be caused by swelling or distension of the gut tube. Colic sometimes is what that's referred to as, or ischemia, deprivation of blood because of arterial problems or maybe twisting of one of the organs so that it's not able to get its blood supply drained through the veins, or even more severely, no drainage to the veins and compression of the arteries so the blood can't even get to the organ in the first place. So when you have long-standing inflammation for any reason, you tend to have a little bit of streaking in the peritoneum as that inflammatory fluid is released into the peritoneal cavity. CT scan tends to be the way to go when you have abdominal pain and some other acute problem like inflammation, severe pain. So abdominal pain with fever, and suggesting infection, elevated white blood cell count, same way, is going to be making us think that there's some sort of an infectious pocket somewhere in the abdominal cavity. So appendicitis, diverticulitis, those are both going to be things that can cause inflammation because of the swelling of the diverticula or the appendix. Natural ileal or Meckel's diverticulum can get blocked and cause similar problems. And those little twisty folds of fat hanging off the colon, the appendices epiploicae, can get twisted on their pedicle and actually cause quite a bit of inflammation despite being little tabs of fat tissue hanging off the colon. So right lower quadrant pain, rebound tenderness, things that are going to be starting to diffuse in the abdomen with pain and then getting more and more localized at McBurney's point, just between the umbilicus and the anterior superior iliac spine, makes you think that appendicitis is fairly likely. So a CT scan with oral contrast or IV contrast might be the way to go so that you're able to assess if the appendix is blocked or enlarged. And here we can see the cecum, nice big air gap right here with the CT scan, and the appendix sticking off in a very kind of frayed appearance here due to the inflammatory fluid that's being leaked from this vessel. Diverticulitis would appear the same way, but generally is going to happen in the distal colon. So the sigmoid colon or the descending colon tend to be the places you have that diverticulitis occur, and that's going to be more localized on the left side. It's not exclusive to there, but that is the tendency. And those little weird appendices epiploicae, if they get twisted, they can also cause a lot of inflammation in the peritoneal cavity, but you don't generally see those as a problem distinctly. They don't show up on CT scan as distinct little things. However, this streaky appearance is going to be due to that inflammatory fluid being leaked into the area by the inflamed appendices epiploicae. They're saying central fat density, maybe it's right there. I don't 100% buy that you can spot that. So anytime you suspect that there might be one of these pockets of inflammation, you really want to get that checked out quickly because if the appendix or one of those diverticula were to rupture, you could have widespread peritonitis and as well as air released into the peritoneal cavity, and you want to make sure that that does not happen if you can help it. Now let's say we have suspected obstruction. So obstruction of the gut tube can occur for many reasons, but one that we've talked about a few times is herniation. So you can have herniation through the anterior body wall, through the diaphragm, through the lumbar region of the body, and essentially if you have bowel sounds outside of the gut, that's a pretty good sign of herniation. If you have an absence of bowel sounds in the abdomen, that may be because of the inflammation and pain that's being experienced by the gut tube, especially if it gets twisted around its pedicle or strangulated, pushed up against some other tough structure in the body as it passes through the hernia, the gap that it's going to be moving through. So what you're looking for is basically bowel where it doesn't belong, and I believe, even if you can't really see that this is proximal bowel that's dilated because of the blockage, I think you can see that here are the layers of the abdominal wall. Here's bowel, and we want that on the inside, not on the outside. Now, the big thing with unintended weight loss and abdominal pain that we are concerned about is cancer, malignancy of cancer right there. Basically, the increased metabolic activity of the tumor cells can lead to unexplained weight loss, and the pain will be visceral referred pain that's coming from the organ, gets referred to different regions of the body. And in this case, we can see that the pancreas, sitting in the abdominal cavity, just anterior to the kidneys, has a mass. Now, you guys are not radiologists. I would never expect you to identify that there's a mass here versus normal pancreas. I really just want you to get a sense of what you would order this imaging for and have that in your back pocket when you guys go into your clinicals. So right here, we can see that something interesting going on. We have actually a relatively rare tumor called a pheochromocytoma, and that's actually going to be a tumor of the medulla, of the adrenal gland, and it's actually going to release excessive epinephrine into the bloodstream. So that is going to be what we see right here, retroperitoneal, just sitting on top of the kidney. We can see the kidney on the left sitting a little bit higher because it's not being pushed down by the liver. All right, now abdominal pain and diarrhea. This can occur for a lot of different reasons. You can have infections, you can have autoimmune reactions that are, robbing your colon of the ability to absorb water. But if you have long-standing diarrheal disease, you can actually wind up thickening of the wall of the colon. And the main thing I want you to see here is that you can actually spot that. And we got a little bit of that fluid, that fat stranding going on here near the inflamed colon. That's kind of an interesting finding right there. That fat stranding just tells you that there's some inflammation, something's going on, and the colon should not have a wall that's quite this thick. Now, dysphagia, difficulty swallowing. This is a biggie, and it's got one of the more interesting methods of being able to actually diagnose. Because we're not in person, I'm not going to just click on these videos. I'll let you guys do that on your own. But this is a short video showing a barium swallow, and you can actually see that the barium during the swallow, instead of going down the esophagus, gets stuck in a posterior not a herniation, but a pouch extending. So what people will tend to complain about when they have one of those pouches sticking off the posterior pharynx is difficulty swallowing or needing multiple swallows or feeling like they've never completely swallowed something. There's something stuck in the back of their throat. And this can be due to weakness in the pharynx. You can have posterior weakness of the pharynx where the muscle bundles, those different pharyngeal constrictors, are kind of connecting with each other, leaving that pouch open and resulting in fluid being retained in the neck rather than making it down the esophagus. Go ahead and check out this video again if you get a chance. Now, if our first step, like ultrasound, video fluoroscopy, or so forth, has not gotten to the source of the complaint, we may have to do another secondary follow-up study. CT, if we haven't done one already, is usually going to be enlisted pretty quickly. And if we think that the reproductive tract is involved, ultrasound is very commonly used to look for things that might be causing pain. And torsion of an ovary, something internal, can definitely happen and cut off its blood supply. If we have fibroids, these are smooth muscle tumors known as leiomyomas of the uterus. They can cause quite a bit of pain as well, and they can actually get quite large, even though they're considered benign because they don't tend to metastasize. An ectopic pregnancy can definitely cause pain, especially as the fetus grows large enough to put demands on the oviduct for a blood supply that it simply cannot handle. And then infections of the oviduct can definitely cause pain, and all of these can be detected by ultrasound, which is relatively quick and accessible. If nothing comes up, then once again we go to CT. If CT is not the first step, it generally tends to be the second step so that we can get a look at what's in there with relatively good visualization of soft tissue and relatively good distinction of the bone from other tissues. So in this case, we have a uterus that has been pushed off to one side here. So what's going on is that we have what's called a pyosalpinx, or an infected uterine tube. The oviduct is infected, and then on subsequent ultrasound we can see this tadpole-looking twisty oviduct is just packed full of purulent material, and that's what a pyosalpinx is. It's a very infected uterine tube. Right here we can see a uterine fibroid. Now we'll have a few videos in a moment about visualizing the uterus with ultrasound. Right here we can just see its outline, little uterine internal endometrial stripe on the inside, and in this case there is going to be an extensive leiomyoma present. It was detected here with ultrasound, but then when CT was ordered you can actually see just how massive it is. It's taking up a huge amount of space, extending up into the abdomen from the pelvis, and even though we don't see the direct connection here, it was sticking off to one side, and we've got this massive growth of a smooth muscle tumor off the uterus. Now, other things that can affect the uterus, we can have polyps, thickened areas of the endometrium, just like we have polyps in the rectum. We can have polyps growing out of the lumen of the uterus as well. Endometrial atrophy, thinning. Endometrial hyperplasia, thickening of that stripe marking the endometrium inside the uterus. And endometrial cancer will often be shown as a thickened stripe. So instead of a nice white line, we have a very thick white line. Most of these that are going to be appearing to be a growth of some sort will make us think about getting a biopsy so we can actually get a pathologic analysis of the tissue and see whether it's actually malignant, benign, or other. So, if someone has enlarged lymph nodes and pelvic pain, and especially if we find a pelvic mass of some sort, this is something we want to treat very seriously because it's likely, not 100% of the time, but likely that we have cancer involved. So pelvic ultrasound is a good first step to characterize almost any pelvic lesion, although CT scan comes in right after that. Abnormal uterine bleeding is a possible sequelae of uterine tumors. However, it's not always that way. There can be other things that cause abnormal uterine bleeding that are either hormonal or due to an overgrowth like a polyp. So looking at that in ultrasound will be pretty important. Urinary tract infections and other infections of the area like pelvic inflammatory disease may show up with laboratory exams, but CT scan will probably be what we go with. An MRI, not a bad option if you're looking at distinguishing different types of soft tissue from each other as well. And not to be forgotten, if you have a woman who's of childbearing age with pelvic pain, getting a pregnancy test looking for human chorionic gonadotropin is an excellent idea. Even if you have ectopic pregnancy, that embryo will still be producing human chorionic gonadotropin, HCG, and that can be detected. And if there's no fetus present in the uterus, you may have to look a little further and see if you can find the fetal evidence of a fetus somewhere else. Again, go ahead and look at these videos and you can see how the appearance of an ectopic pregnancy will appear on ultrasound. I should also warn you, physicians and other healthcare professionals on YouTube really like to put background music in their videos. I don't understand it. So at least several of these videos that I'm referencing in this lecture have bizarrely, not inappropriate, but just music that doesn't really add anything to it. So feel free to mute as needed as you go through this. I didn't select the music, and I certainly didn't pick these videos for that. Now, another cause of pelvic pain, you can diagnose with ultrasound are going to be ovarian cysts. Now, ovarian cysts can have a variety of appearances. Generally, they tend to be fluid-filled pouches, and right here we can see, instead of a nice, relatively solid ovary, we've got lots of fluid-filled spaces here. One characteristic of fluid on ultrasound is it causes enhancement posterior. Because fluid transmits sound waves so well, it actually enhances the area behind it. So that's why we have this nice bright area just past all these fluid-filled spaces. Whereas solid objects like the gallstone we saw at the very beginning tend to cause shadowing posterior to it. So here we have a hemorrhagic ovarian cyst. So we have a cyst that actually started bleeding and resulted in pelvic pain, and that's why the person came into the physician in the first place. So you can see that it's not just fluid. There's some hemorrhaging, possibly some clotted blood here, making it kind of a weird mix of appearance on ultrasound. Now, once again, this is not ultrasound class. I just want you to get a sense of how ovaries can appear a lot of different ways depending on whether there's a pure fluid-filled cyst involved or if there's some solid tissue interrupted with fluid, interrupted with clot, and so forth. Now, torsion of the ovary and oviduct can be incredibly serious. They can twist around the ovarian ligament, linking the ovary to the uterus, and twisting is going to shut off the blood drainage from those organs, and that's bad news. If you can't have venous return, the organs get swollen and painful. If you wind up with excessive torsion, you can also start compromising the arterial blood supply, but both are bad. Both are going to cause severe acute pelvic pain, and it has to be dealt with because otherwise it will cause these tissues to die and get necrosis in there. So generally it's going to be similar to appendicitis, very severe referred pain, but it may go to either the left or right depending on which ovary and oviduct are involved. So go ahead and check out the video. It's a very long, not very, but it's a relatively long video. You really only need to check out the first 3 minutes or so. So let's go back to those uterine fibroids. So here, the fibroids, if they're small, can be left alone. You can see that they have a variable appearance, but what's interesting is fibroids tend to have this interesting Venetian blind appearance. So if you see kind of the shadowy enhanced, shadowy enhanced, shadowy enhanced appearance, that tends to be what the fibroids of the uterus appear like. And here we went around and the physicians got an MRI. You can just see this monstrous fibroid right here sitting on top of the bladder. That can't feel great. And we got the abdominal wall here being pushed forward by that fibroid. Probably a little bit of a secondary growth back here. So just be aware, one imaging modality is not all you have to work with, but CT or ultrasound in the abdomen and pelvis tend to be a good starting place. Now here's a fibroid that has some problems in that it grew so large it outgrew its blood supply and it started to hemorrhage. So we basically had tissue inside the fibroid die, and then the blood supply to that dead tissue started leaking into that area. So we have a fibroid that had been solid, then became necrotic, and here we can see on MRI that standing fluid. So we have a T2 MRI here demonstrating that there's a lot of fluid inside that necrotic section. Now here is a very interesting case. We have a pelvic mass causing pelvic pain, and look at that. We got an area with a little dark here, and we've got enhancement. So there's fluid there. Then we have another area that's dark, shadowy there. So it's like we have something that's liquid, something that's solid, something that's liquid, something that's solid. Very kind of weird pattern posteriorly. CT scan shows something similar. We have fluid and solidity, something very solid, looks like bone in there that was causing pelvic pain. And what do we have in this case? What is it? This is an ovarian dermoid. This is a tumor that can sometimes form as a result of an unfertilized egg that somehow gets it into its mind to start dividing as though it's a blastocyst and starts just pumping out tissues. And it will make things of ectoderm, endoderm, or mesodermal origin. In this case, we have a pretty perfect looking tooth sticking out of this ovarian dermoid. So dermoid cysts can result in multiple tissues forming. You can also have what's called a teratoma, or a monster tumor, that just starts pumping out different kinds of tissues in a very disorganized manner. So it's not the only thing that can cause that, but it's definitely pretty notable when you see it. Now, just like ovaries and the oviducts can get twisted, we can also have scrotal masses and pain that occur due to testicular torsion. If a testy gets twisted, it shuts down its blood supply, venous drainage more or less ceases, and the testicle and surrounding area fills with venous blood that can't drain. This is going to be suddenly acutely painful. It tends to affect adolescent boys. Can affect any boy or any male, but it tends to be in early adolescence that this tends to happen. It's acutely painful, so any male who comes in with acute pain in the scrotum, you want to think testicular torsion is somewhere on your differential list. Ultrasound is going to show that you've got a definite lack of blood flow through there, basically because of the twisting of the testy on its pedicle, or that testicular ligament that's left over from the gubernaculum. Now remember that those testicular tags are remnants of the paramesonephric duct. Occasionally, those can even twist on their own blood supply and cause pretty acharacteristically severe pain for something so minor. So it's not going to be as severe, but it's very strange that you could have a tiny little tag like that cause such pain that might be mistaken for testicular torsion, but wouldn't have the same sort of ultrasound findings. Now, inflammation or infection of the epididymis can also happen. People who have to be straining during exercise can sometimes actually develop that. And urinary tract infections can also affect males. Since the urinary and reproductive tracts are so closely aligned, you can actually have them affecting each other simultaneously. So this very short video here you can click on and just see some of the differences in ultrasound with Doppler on the affected side versus the unaffected side. And remember on Doppler that red means that the fluid is moving towards the probe, blue means that the fluid is moving away from the probe. Another thing that can happen in the scrotum is called a varicocele. These are basically varicose veins around the testicle. So it has a bag of worms appearance, which you can kind of make out here on this static shot, but this is another short video, so go ahead and click on this and just take a look at what those enlarged veins in the scrotum look like. The varicocele is different from a hydrocele, which is going to be just fluid in a cyst in the scrotum, whereas hematoceles are filled with blood, and specifically a varicocele is going to be distended veins. So there is blood moving through them, they're just distended. And in this video you actually see at one point they ask the person to bear down, and you'll just see those swell right back up. Now, testicular masses are going to be interesting in that you want to be suspicious of possible testicular cancer, and you can use ultrasound as a way to get a look at that prior to doing a biopsy, something a little more invasive. So infection may be ruled out. Ultrasound can determine if you have a cryptorchid testy somewhere along the line between the body wall and the scrotum, so you can actually look for the testicle trapped inside the inguinal canal. That's what's being shown here, and that can be useful if you have a child who's born with an undescended testy and it still hasn't descended after a few days following delivery. Now, let's jump over to the idea of, or to the renal system real quick, and just see how imaging might help us out there. Bleeding is always something you want to take seriously, especially if it's going to be blood in the urine. You have the potential for cancers or trauma resulting from that. So hematuria, or blood in the urine, can occur for lots of reasons. It can be exercise-induced, especially if someone is in a contact sport. You can have urinary tract infections that cause bleeding into the bladder, the urethra, the ureter, and so forth. Dehydration, interestingly, can do it. And just anything that damages the kidneys, like a myocardial infarction or too much protein in the blood, that can all result in that. But tumors are yet another reason we might have blood in the urine, and we want to make sure that you're using imaging to get to the root of that if at all possible. So here we've got a kidney and we've got CT scan. And one interesting thing about the urinary system is a lot of use is made of an image with and without contrast. So here's without contrast. We can see the kidney here. It's got a little lump here. So we're wondering what's going on there. Then when the contrast is added, we can see that the contrast material has been filtered by the kidney. It's filling it up, but we have a little bit of a weird outline. So we have some growth here, giving us a little more characteristic of where the normal versus abnormal sections of the kidney are. And some masses are not all masses that we have to track and do surgery on. This is showing a kidney mass that's present at one point, and then 5 years later, the mass is the same. So maybe a little bit of a fatty lipoma there that isn't going to cause too many problems. If you know it's there, you can always track it thereafter. Now, one interesting cause of hematuria is going to be the ureters. And the ureters can get damaged by a kidney stone working its way down. That can be one cause, along with the pain in the posterior lateral flank. It's a pretty clear idea that you might be dealing with a kidney stone. So here we've got the ureter showing up bright white, not because it's got a stone in it, but because it has contrast material being applied to the bloodstream, filtered by the kidneys, and released. And that's allowing the person examining these pictures to see that there's a big bulge on the posterior side of this ureter compared to the one over here on the healthy side. So we actually have a tumor present in that area, and then a coronal section demonstrates the location of that tumor along its course. This one is particularly interesting in that we waited till the contrast media got to the bladder itself, and when the contrast media filled up the urine, we can actually see that there's a very significant mass on the posterior wall of the bladder here. So it's actually allowing us to see that. You can kind of make that contrast out here on the left without the contrast media in there, but it's much easier to see once that's present. So when somebody has symptoms of a renal stone, intense pain, the standard choice to start with is called a KUB. I think we've mentioned this before, but it's basically a CT scan without contrast. And it's without contrast because that stone shows up bright white no matter what. But if I have contrast material in the area, it's going to wash that out and possibly obscure the presence of that stone. So hydronephrosis is also something we can see on CT, but also on ultrasound, and we'll have a whole little slide on that in just a moment. But hydronephrosis, possibly caused by a tumor of the ureter or blockage of the ureter by a kidney stone, is backing up the urine into the ureter, the renal pelvis, and all the way back into the kidney. So right here we have the left side of the body, normal. Here's the right side of the body, and you can see that ballooned out area where the urine is draining. So there's some blockage somewhere. Here we've done an intravenous pyelogram. We generally don't see these too much anymore, but you can indeed inject material up into this area and visualize the drainage of the kidney with a kind of a retrograde application of that contrast medium. That's not as common anymore. Here is a nice example of what I was getting at earlier, where we can see an asymptomatic kidney stone in the kidney here, but as the contrast media gets into the blood and gets filtered by the kidney, that stone becomes almost impossible to find. And if need be, you can also directly visualize the ureter with a cystoscopy, taking a probe and actually directing it up through the urethra, into the bladder, into the ureter, and here, kidney stone, that looks horrendously painful, and tumor, also bad, both possibly causing bleeding into the urine. Now, these are videos that I think it's a really good idea to get a good look at. They're really well done, and they're showing the different grades, especially this one on the right, how you can use ultrasound to quickly grade the different types of hydronephrosis. Now, I don't want you to memorize what makes one grade another. Just know that you've got varying grades depending on how distended the urinary drainage apparatus is by the inability of the urine to get past a blockage somewhere further down the way. Now, ultrasound is great. Another reason it's great is because not all people can handle the IV scans, especially with what's gadolinium as a contrast agent. People with kidney issues and people in renal failure cannot be given that because there's a rare but very, very nasty side effect called nephrogenic systemic fibrosis. So one last thing before you guys leave anatomy and go out into the world in your clinicals next year is just make sure that you've always assessed the renal competency of somebody prior to giving them any kind of a IV scan, especially if you're going to use gadolinium as a contrast agent. All right, I look forward to talking to you guys soon. It's been excellent despite all the problems we've had with the pandemic. Just let me know if you have any problems, and I look forward to hearing from you. Have a great day.